Hello everybody. Welcome to number 1 Doctor channel. Today video is about pediatric surgery, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel number 1 Doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about pediatric surgery. Birth through the first 24 hours. Most congenital anomalies require surgical correction, but in many of them other anomalies have to be looked for first. In some cases clusters are seen. Esophageal atresia shows up with excessive salivation noted shortly after birth, or choking spells when first feeding is attempted. A small NG tube is passed, and it will be seen coiled in the upper chest when X-rays are done. If there is normal gas pattern in the bowel, the baby has the most common form of the 4 types, in which there is a blind pouch in the upper esophagus and a fistula between the lower esophagus and the tracheobronchial tree. Before therapy is undertaken, associated anomalies the vertebral, anal, cardiac, tracheal, esophageal, renal, and radial vector constellation have to be ruled out. Look at the anus for imperforation, check the X-ray for vertebral and radial anomalies, do echocardiogram looking for cardiac anomalies, and sonogram looking for renal anomalies. Primary surgical repair is preferred, but if it has to be delayed, a gastrostomy has to be done to protect the lungs from acid reflux. Imperforate anus may be the clinical presentation noted on physical exam for the vector collection of anomalies. If so, the others have to be ruled out as detailed above. For the imperforate anus itself, look for a fistula nearby to vagina or perineum. If present, repair can be delayed until further growth but before toilet training time. If not, a colostomy needs to be done for high rectal pouches and later the repair, or a primary repair can be done right away if the blind pouch is almost at the anus. The level of the pouch is determined with X-rays taken upside down so that the gas in the pouch goes up, with a metal marker taped to the anus. Congenital diaphragmatic hernia is always on the left, and the bowel will be up in the chest. The real problem is not the mechanical one, but the hypoplastic lung that still has fetal-type circulation. Repair must be delayed 3 or 4 days to allow maturation. Babies are in respiratory distress and need endotracheal intubation, low-pressure ventilation, careful not to blow up the other lung, sedation, and NG suction. Prenatal sonogram is diagnostic. Very severe cases that do not respond to conventional therapy are treated with extracorporeal membrane oxygenation (ECMO). The patients in these cases are children who would otherwise die, a circumstance that justifies this very expensive procedure. But ECMO is not a panacea in this setting. Early mortality from neurological complications, including intracranial bleeding, is very high, and the long-term health of the survivors is uncertain. Some have experienced continued pulmonary function deterioration and severe developmental problems. Gastroschisis and omphalocele show up with an abdominal wall defect in the middle of the belly. In gastroschisis the cord is normal, it reaches the baby, the defect is to the right of the cord, there is no protective membrane, and the bowel looks angry and matted. In omphalocele the cord goes to the defect, which has a thin membrane under which one can see normal-looking bowel and a little slice of liver. Small defects can be closed primarily, but large ones require construction of a silastic silo to house and protect the bowel. The contents of the silo are then squeezed into the belly, a little bit every day, until complete closure can be done in about a week. Babies with gastroschisis also need vascular access for parenteral nutrition, because the angry-looking bowel will not work for about 1 month. Exstrophy of the urinary bladder is also an abdominal wall defect, but over the pubis, which is not fused, with a medallion of red bladder mucosa, wet and shining with urine. The baby has to be transferred immediately to a specialized center where a repair can be done within the first 1 or 2 days of life. Delayed repairs do not work. Green vomiting in the newborn has ominous significance. green vomiting and a double bubble picture in X-rays. A large air fluid level in the stomach, and a smaller one to its right in the first portion of the duodenum are found in duodenal atresia, annular pancreas, or malrotation. All of these anomalies require surgical correction, but malrotation is the most dangerous because the bowel can twist on itself, cut off its blood supply, and die. If in addition to the double bubble there is a little normal gas pattern beyond, the chances of malrotation are higher. Malrotation is diagnosed with contrast enema safe, but not always diagnostic or upper GI study more reliable, but more risky. Although described here as a problem of the newborn, the first signs of malrotation can show up at any time within the first few weeks of life. Intestinal atresia also shows up with green vomiting, but instead of a double bubble there are multiple air fluid levels throughout the abdomen. There may be more than one atretic area, but no other congenital anomalies have to be suspected because this condition results from a vascular accident in utero. A few days old through the first 2 months of life. Necrotizing enterocolitis is seen in premature infants when they are first fed. There is feeding intolerance, abdominal distension, and a rapidly dropping platelet count in babies, a sign of sepsis. Treatment: stop all feedings and administer broad-spectrum antibiotics, for fluids, and for nutrition. Surgical intervention is required if the infant develops abdominal wall erythema, air in the portal vein, intestinal pneumatosis, presence of gas in the bowel wall, or pneumoperitoneum, signs of intestinal necrosis and perforation. Meconium ileus is seen in babies who have cystic fibrosis, often hinted at by the mother having it. They develop feeding intolerance and bilious vomiting. X-rays show multiple dilated loops of small bowel and a ground glass appearance in the lower abdomen. Gastrogaphan enema is both diagnostic microcolon and inspissated pellets of meconium in the terminal ileum, and therapeutic. Gastrogaphan draws fluid in, dissolves the pellets. Hypertrophic pyloric stenosis shows up at age 3 weeks, more commonly in firstborn boys, with non-bilious projectile vomiting after each feeding. The baby is hungry and eager to eat again after he vomits. By the time they are seen they are dehydrated, with visible gastric peristaltic waves and a palpable olive-size mass in the right upper quadrant. If the mass cannot be felt, a sonogram is diagnostic. Therapy begins with rehydration and correction of the hypochloremic, hypokalemic metabolic alkalosis, followed by Ramstedt pyloneotomy or balloon dilatation. Biliary atresia should be suspected in 6 to 8-week-old babies who have persistent, progressively increasing jaundice, which includes a substantial conjugated fraction. Do serologies and sweat test to rule out other problems, and do HIDA scan after 1 week of phenobarbital, which is a powerful choleretic. If no bile reaches the duodenum even with phenobarbital stimulation, surgical exploration is needed. About 1/3 can get a long-lasting surgical derivation, about 1/3 need a liver transplant after they survived for a while with a surgical derivation, and about 1/3 need the transplant right away. Hirschsprung disease, a ganglionic megacolon, can be recognized in early life or may go undiagnosed for many years. The cardinal symptom is chronic constipation. With short segments, rectal exand may lead to explosive expulsion of stool and flatus, with relief of abdominal distension. In older kids in whom differential diagnosis with psychogenic problems is an issue, presence of fecal soiling suggests the latter. X-rays show distended proximal colon, the normal one, and normal-looking distal colon, which is the aganglionic part. Diagnosis is made with full-thickness biopsy of rectal mucosa. Ingenious operations have been devised to preserve the unique sensory input of the motor-impaired rectum, while adding the normal propulsive capability of the innervated colon. Later in infancy, intussusception is seen in 6 to 12-month-old chubby, healthy-looking kids who have episodes of colicky abdominal pain that makes them double up and squat. The pain lasts for about 1 minute, and the kid looks perfectly happy and normal until he gets another colic. Physical exam shows a vague mass on the right side of the abdomen, an empty right lower quadrant, and current jelly stools. Barium or air enema is both diagnostic and therapeutic. If reduction is not achieved radiologically or if there are recurrences, surgery is done. Child abuse should always be suspected when injuries cannot be properly accounted for. Some classic presentations include subdural hematoma plus retinal hemorrhages, shaken baby syndrome, multiple fractures in different bones at different stages of healing, and all scalding burns, particularly burns of both buttocks. The child was held by arms and legs and dipped into boiling water. Meckel diverticulum should be suspected in lower GI bleeding in the pediatric age group. Do radioisotope scan technetium looking for gastric mucosa in the lower abdomen. Undescended testicle that has not reached the scrotum by the age of 1 needs to be surgically brought down there and fixed in place or chiopexy. Note that a testicle that is in the canal at birth, but can be easily pulled down where it belongs, is not an undescended testicle, it is an overactive cremasteric muscle. Parents need to be reassured of the benign nature of the latter. Abdominal masses in children are typically discovered by the mother. Mothers constantly handle their babies, are very familiar with their anatomy, and immediately recognize a change. If, on examination, the mass moves up and down with respiration, it is most likely a malignant liver tumor, hepatoblastoma or hepatocellular carcinoma. Alpha-fetoprotein is likely to be elevated. If the mass is deeper and non-mobile, there is an even chance that it is a Wilms tumor arising from the kidney or a neuroblastoma growing in the adrenal gland. Modern imaging devices, CT scan, MRI, can easily clarify what it is. Most of these malignancies are treated with surgical resection, if possible, and often they are subjected to additional chemotherapy or radiation. The prognosis in neuroblastoma depends on the child's age when it is discovered. The younger the patient is, the better the cure rate. A curious added feature of the neuroblastoma is that it may involute and spontaneously revert to a benign neuroma. Childhood leukemia may be cured in the near future, if current trials with genetically modified immune cells CAR T-cell therapy are successful. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atef Ahmed wishes. Dr. Atef Ahmed wishes.